groups, either infectious or non-infectious, and all of them have different ways of diagnosis and treatment. I always tell the patient, any organism on earth can cause uveitis, because we have bacterial causes, viral causes, parasitic, and fungal, and all these organisms know. So any infection can cause uveitis, or it can be non-infectious. And in fact, non-infectious causes can be with systemic association or only in the eye. And it can be in the eye without any systemic association, and this is the majority of the cases. So I always tell our colleagues and our patients and ourselves, if you don't find a positive lab, don't be frustrated, and tell your patient this is what happens in 50% of cases or more. We have idiopathic causes or cases of uveitis. And the last group are the masquerades. Sorry. We have the masquerades. We have neoplastic and non-neoplastic. We are all familiar about neoplastic causes of uveitis, but what are the non-neoplastic? The most famous is the retinal detachment, acute retinal detachment. I have seen cases, several cases that were misdiagnosed as uveitis, and in fact, they had acute retinal detachment, especially if they have cataract. In these cases, I think this scan is important. So how would we work the patient in order to reach a diagnosis? There are several systems in the literature, but in fact, I don't rely on this heavy things like naming and meshing and classification. We can follow our routine work in the usual cases. The diagnosis depends on taking good history and performing clinical investigations, clinical examination, and then asking for the appropriate investigations according to the clinical scenario. And this is what we do with the cases of diabetes and hypertension. Anything in ophthalmology. The first, history. For us as uveitis specialists, history is very important and integral part in order to reach the correct diagnosis. We have two types of obtaining history from our patients, and I work with both. We can have a preset uveitis questionnaire, when you can have a print in your clinic and you give the patient while he is waiting in the waiting area to fill it, and this is very good. And you have the direct inquiry or direct interview. I practice both, but I find the direct interview is very important. I may spend more than 15 to 20 minutes talking to the patient. And believe me, this makes magic with your patient, because you will understand what is his fears, what is the main problem we have. The second, you will build a good relation with the patient. He will believe you later. When you ask him to do investigations, he will do. The problem in uveitis, we ask for many labs. If the patient is not convinced that you listen to him accurately and you spotted his problem, he will not follow your orders. So I prefer to ask the patient by myself, and I make a scheme in my mind, and I always talk to the patient, and this gives marvelous results. The second is the clinical evaluation. As we can see here, we have multiple and many signs of uveitis, different signs. We can have ciliary injection, we can have osteosynegia, we can have anterior segment flare, we can have cells, different types of kidneys. So I think, and our colleagues will cover this in the upcoming talks, how to use this clinical science in narrowing the differential diagnosis. All what we do is we try to tailor or narrow the differential diagnosis from 150 causes to 1 or 2 causes. So in order to standardize the nomenclature for the uveitis specialists, some working group was a milestone in the studies and the clinical practice of uveitis, in fact. And this group put an objective to standardize the methods of reporting clinical data in the field field of uveitis. Is this important? Yes. It's important in clinical practice and in the research. Because, for example, when I'm referring a case to my colleague and brother, Dr. Muhammad Abdelazim, I will tell him, Dr. Muhammad, I have a case of uveitis with 2+ cells and 2+ flare with the retinal vasculitis is acute or chronic. So we must have a standardized nomenclature in the diagnosis and in the grading scheme and in the outcome measures. And this was the mission of the Sun working group. I will not go to the details of these tables. I think all of you are aware of this. But simply, we put a classification for, anatomical classification for uveitis, anterior uveitis where inflammation affects mainly the iris and the ciliary body. Intermediate uveitis when inflammation affects the vitreous and the periphery of the retina. And posterior uveitis where inflammation affects the choroid with or without the overlying retina, and of course the rare benign uveitis when all parts of the uvea are affected. The second is inflammation grading. So you think that inflammation in your left hand side, like inflammation in the right? Of course no. How can we describe this? All these two patients have flare and cells. The one in the left have milder, but we have to have a proper way for documentation of our findings, for at least follow-up, to know if the patient improved or not. So the Sun working group put a grading criteria, and all of you also are aware of this, and I encourage all of you who are practicing uveitis or even general ophthalmologists to use this scheme for follow-up and for reporting the outcomes. The last thing is the outcome measures, and I think all of us also are familiar about this table where we classify the outcome measures according to the onset, duration, and the course. Lastly, investigations of uveitis. I will not talk about investigation, but this is the most commonly asked question. What investigation I would do for a case of uveitis? I promise you, inshallah, the answer will come in the upcoming talkings. But the question is there a standardized battery of tests that we can all do for all cases of uveitis? Unfortunately, the answer is no. Thank you so much, and I hope you enjoyed.